Important features of vitamin D are discussed in this video. Vitamin D is either synthesized in the skin from the sunlight or it is absorbed from the gastrointestinal tract from the dietary sources such as dairy, fish oils, or fortified food. However, this is inactive form and must be converted into active form to have physiological effect. In the liver, the cholecalciferol is converted into 25 hydroxycholecalciferol, and this is the major circulating form and is used to assess vitamin D status in the blood test. In the kidney, 25 hydroxy D3 is further hydroxylated to become 125 dihydroxycholecalciferol, also known as calcitriol. This is the active form of vitamin D. So this increases the calcium absorption in the small intestine and promotes phosphate absorption for the bone mineralization also. It stimulates bone remodeling by enhancing the resorption of the bone indirectly and aiding the osteoblast activity for new bone formation. It also supports the renal calcium reabsorption. So the kidneys activation step is tightly regulated by parathyroid hormone that enhances the activation in response to low calcium. While calcium and phosphate level, if high, they inhibit the calcitriol formation. Vitamin D is derived from estrol that give rise to many compounds. These are closely related and got same function, almost same function. So the 7-dehydrocholesterol is the cholesterol derivative that is present naturally in the skin, and by the action of ultraviolet rays, it is uh, it is converted into vitamin D3. This ultraviolet rays wavelength is 290 to 315 nanometer ultraviolet B rays, and the resultant product is vitamin D3 or cholecalciferol. This is a pre-hormone or inactive form of vitamin D, and this conversion, sun exposure is necessary. So sun exposure prevent the deficiency of this one. So sunlight exposure is essential for initiation of this reaction. This is a non-enzymatic process, and after formation, this cholecalciferol this enters into the bloodstream and is transported to the liver for further conversion into active hormone. The ingested form of vitamin D compounds are identical to the cholecalciferol that is formed in the skin, except for a few substitutions, and these substitutions do not affect their function. So cholecalciferol is converted in the liver into 25 hydroxycholecalciferol, and there is a feedback inhibitory effect of this reaction. If the concentration of this increases, then it blocks the cholecalciferol. This reaction occurs in the liver, and the enzyme involved is 25 hydroxylase. The 20 the 25 hydroxylase causes the cholecalciferol to form 25 hydroxycholecalciferol, and this is a self-limiting procedure because high level of these D3 they inhibit further conversion of vitamin D3, and this prevent the toxicity and overactivity. So vitamin D3 storage is in the liver, and there is sufficient supply even for months in the liver. But once converted into 25 hydroxy cholecalciferol, it may only last a few weeks. So this reaction maintains a stable blood level of 25 hydroxy cholecalciferol that prevent overactivation even if dietary or sunlight dry vitamin D3 increases significantly. So there is a regulation of calcium and phosphate metabolism without causing overload. This graph is illustrating the regulatory feedback mechanism in the conversion of vitamin D3 to 25-hydroxycholecalciferol in the liver. On the x-axis, there is intake of the vitamin D3 is given in multiples of the normal level, and on the y-axis, the plasma 25-hydroxycholecalciferol levels in multiples of the normal levels are given. So this show there is a sharp rapid rise in 25 hydroxycholecalciferol with increasing vitamin D3 intake followed by a plateau once it reaches the normal range. So this liver efficiently converted vitamin D3 to 25 hydroxy D3 at low intake levels. However, as intake increases, the conversion slows down and plasma 25 hydroxy cholecalciferol level it stabilizes, staying within a narrow normal range. This is due to feedback inhibition, and this 25 hydroxy cholecalciferol inhibits further conversion, preventing excess accumulation. So the body has got a tendency for natural regulation to maintain a stable level of 25 hydroxycholecalciferol. Even when vitamin D3 intake it increases significantly, and this process, this mechanism prevents the vitamin D toxicity. So here the final and most critical step in activating the vitamin D and highlighting the role of the kidney and parathyroid hormone. So cholecalciferol is first converted into the 25 hydroxycholecalciferol in the liver, and this compound is then further converted in the proximal tubule of the kidney to 125 dihydroxy cholecalciferol, the most biologically active form of the vitamin D. 125 dihydroxy cholecalciferol is 1000 times more potent than the earlier form of the vitamin D. So without kidneys, this crucial conversion cannot occur. So vitamin D becomes ineffective. There is a role of parathyroid hormone in this process. It is essential for this kidney-based conversion. In the absence of parathyroid hormone, production of 125 dihydroxycholecalciferol is severely impaired or halted. So this parathyroid hormone determines how active vitamin D is in the body. So in the conditions like hyperparathyroidism or chronic kidney disease, the activation of vitamin D is impaired and affecting calcium absorption, bone health, and balance of the mineral. There is inverse relationship between plasma calcium and calcitriol formation. As plasma calcium level increases, As plasma calcium level increases, the formation of 125 dihydroxy cholecalciferol decreases, and as plasma calcium decreases, the formation of 125 dihydroxy cholecalciferol increases. Why this happens, why there is direct inhibition of calcium? There is elevated calcium level that inhibit the conversion of 125 dihydroxy a conversion of 25 hydroxycholecalciferol into 125 dihydroxycholecalciferol in the kidney. So the low calcium stimulates the parathyroid hormone, and this parathyroid hormone enhances this conversion in the kidney, boosting the active vitamin D production while calcium is low. This inverse regulation ensures that while calcium is low, more active vitamin D is produced to increase the calcium reabsorption from the gut and mobilize calcium from the bone. When calcium is high, the production of active vitamin D, it decreases to prevent hypercalcemia. So on the x-axis there is given this plasma calcium concentration in milligram per 100 ml, and on the y-axis 125 dihydroxycholecalciferol is given in the as the multiple of the normal. So at low calcium level, over here in the left side of the graph, the plasma 125 dihydroxycholecalciferol is high, up to 5 to 6 times of the normal. This reflects the body's attempt to increase the calcium absorption from the gut and mobilize calcium from the bone. As calcium approaches normal level around 9.4 to 10 milligram per 100 ml, there is a sharp drop in 125 dihydroxycholecalciferol level. This is a feedback mechanism to prevent excess calcium level. At high calcium level, that is this right side of the graph, 125 dihydroxycholecalciferol production is almost shut off. The kidneys stop this conversion of the active hormone. So this represents that the body tightly regulates calcium through hormone signaling. When calcium is low, more active vitamin D is made to boost its absorption. When calcium is high, the conversion halts to prevent the overload. This concept is reiterated here. There is inverse relationship between plasma concentration of 125 dihydroxycholecalciferol and calcium in the plasma. So when plasma calcium, that is normally about 9 to 10 milligram per 100 ml, when it is decreased, there is release of this parathyroid hormone, and in the kidney, the 25 hydroxycholecalciferol under the hormone influence, it is converted into 125 dihydroxycholecalciferol. This causes the increase in calcium absorption from the intestine, bone, and kidney. When calcium is high, this parathyroid hormone is suppressed, and this vitamin D, 25 hydroxycholecalciferol, instead of conversion into 125, it is converted into a less active form, that is 24-25 hydroxycholecalciferol, which has minimal calcium regulating effect. So this high calcium will result in low calcium absorption from the gut, kidney and bone. So the calcium level returns to normal. This mechanism ensures that the calcium level stay within a narrow, safe range, and this calcium level is automatically corrected through signaling of the hormone, and the hypercalcemia or high calcium or hypocalcemia or low calciums are prevented. What are the actions of 125 dihydroxycholecalciferol or active vitamin D? The goal is to increase calcium absorption and increase phosphate absorption, or to increase calcium and phosphate level in the extracellular fluid by enhancing absorption, reabsorption and mobilization. From the intestine, there is increased calcium absorption because this vitamin D3 stimulates the synthesis of calcium binding proteins such as calbindin in intestinal epithelial cell, and it enhances sodium phosphate co-transporter for increased phosphate absorption, and in the kidney it helps conserve calcium. Vitamin D and parathyroid hormone synergy is described earlier in the distal tubule, and in the bone there is stimulation of the osteoblast that promote the formation of the bone initially, and in the presence of parathyroid hormone it stimulates the osteoclast formation via a rank ligand and increase bone resorption that will lead to release of calcium and phosphate into the blood. Then this also acts as a double-edged sword, help to form bone and also release minerals when needed. When calcium levels are high, formation of 125 dihydroxycholecalciferol is suppressed, and when calcium is low, parathyroid hormone stimulates its formation in the kidney. So vitamin D receptors or VDR, they are present in most cells of the body and located mostly and mainly in the nucleus of the target cells. They are structurally similar to the steroid and thyroid hormone receptor. Vitamin D receptors has two critical domains, hormone binding domain and DNA binding domain. This vitamin D receptor form a complex with the retinoid X receptor, and this complex, vitamin D receptor and retinoid X receptor, they bind DNA at vitamin D response element, and it modulates the gene transcription, usually activate transcription of genes such as calcium binding protein, and sometimes suppress the transcription depending on the gene and context. This vitamin D receptor has 1000 times greater affinity for 125 dihydroxycholecalciferol, that is the active form of the vitamin D. This explains why 125 dihydroxycholecalciferol is biologically potent form of vitamin D. So, what is the physiological importance of this? It regulates the expression of calcium and phosphate homeostasis gene, influences gene in bone metabolism, immune modulation, and cell proliferation and differentiation. 125 hydroxycholecalciferol, that is the active form of the vitamin D, has got some hormonal effect also. It increases the production of calcium binding protein, cal binding, and this cal binding causes the increased transport of the calcium from the extracellular cells to the intestinal extracellular fluid to the intestinal epithelial cell, and then there is facilitated diffusion of this calcium into the body. So this effect takes about 2 days, and it remains for several weeks uh, if the hormone is gone. So it is a prolonged effect. Then the vitamin D3 also causes calcium stimulated ATPase formation in the brush border, and also causes increased alkaline phosphatase in the epithelial cells. The exact roles are not fully understood. It also causes the phosphate absorption in the intestinal epithelium, and it is a direct effect of this cholecalciferol, or possibly indirect via this calcium mediated transport. There is some effect on the kidney also, that is a weak effect, and it slightly enhances the reabsorption of calcium and phosphate in the renal tubules. So the calcium and phosphate excretion is also decreased. In the bone metabolism, vitamin D has got a dual role. It promotes both the bone resorption and bone deposition. In high doses, vitamin D promotes bone resorption, likely due to increased calcium transport across the bone cell membrane, and it supports the bone resorption effect of the parathyroid hormone. Without vitamin D, the parathyroid hormone induced bone resorption is blunted or failed. In a small physiological amount, the vitamin D promotes bone calcification or bone deposition. It enhances the calcium and phosphate absorption from the intestine, increasing the availability of the bone mineralization. And even without increased mineral level in the plasma, it stimulates the deposition of the mineral in the bone matrix. The mechanism is increased transcellular calcium ion transport, likely modulates osteoblast and osteocyte membrane transport process, and many promote resorption when moving calcium out of the bone cells, may promote mineralization when moving calcium into the bone matrix. So this process is depend. What is the dependency of this process on parathyroid hormone? The parathyroid hormone, it requires vitamin D to effectively activate osteoclast indirectly via osteoblasts. So it also parathyroid hormone also promote calcium release from the bone. Without sufficient active vitamin D, parathyroid hormone's catabolic effect on the bone are weakened. Thank you for watching this video. If you have any query, please write in the comment box.